Good afternoon, everyone. Thank you for joining today's webinar on closing the coverage coordination gap for dual eligibles. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. And for those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. The Alliance gratefully acknowledges Arnold Ventures for supporting today's webinar. And I am pleased, without further ado, to introduce Ariel Mir, Vice President of Healthcare, who is overseeing complex care at Arnold Ventures, to make some brief opening remarks. Ariel, welcome.
Thank you, Sarah. Welcome, everyone. My name is Ariel Mir, and I lead the Complex Care Program at Arnold Ventures. Thanks to you all for showing up to this conversation today. It's one of the most important issues that most folks are not talking about, and that's what happens to the 12 million people whose care is delivered at the intersection of Medicare and Medicaid. Next slide, please. You might think that having two sources of insurance coverage would be better than having just one, but that's not always true for the low-income seniors and people with disabilities who get their coverage this way. Because Medicare and Medicaid were not designed to work together, the people who have both, the people who we call in policy circles dual eligible, often receive fragmented, uncoordinated care that leads to poor outcomes for individuals and high costs for the program. We at Arnold Ventures see an opportunity to change that trajectory by promoting models that integrate Medicare and Medicaid into single, unified, coordinated programs. Next slide, please. There is a lot more to say about what these models are and what they could be, and what it will take for all people with Medicare and Medicaid to have access to enrolling in these models. But I was going to spend a moment to get beyond the policy jargon to emphasize what we are talking about when we talk about dual eligibles. We are talking about people who are very low income, whose access to social supports puts their health at risk. We are talking about folks who have trouble with activities of daily living, who have trouble eating, dressing, moving from place to place. Many of them live in nursing homes, which, as we know, meant higher hospitalizations and deaths from COVID-19. And we are talking about a glaring health equity issue. A greater share of this population are people who are Black and Latino than in the Medicare-only population. I'll stop there and turn it over to our panel for today. We'll tell you more about why this population and these programs need your attention, what programs have potential for change, and what the Congress and states can do to make an impact here. Thanks again for coming.
Great. Thank you so much, Ariel, for that context and those opening remarks. And I want to go over some very quick housekeeping items, and then I'll introduce our panelists. First, let me remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive. Join our community at All Health Policy as well on Facebook and LinkedIn. Please get your questions ready. You should see a dashboard on the right side of your web browser with a speech bubble icon. Go ahead and use that to submit questions at any time. We'll get to as many as we can during the broadcast, as well as if you have any technical issues, you can go ahead and chat them there as well. And finally, check out our website, allhealthpolicy.org, where you can find background materials, including a resource list and an expert list, and later today, a recording of today's webinar. As Ariel mentioned, this is a topic that has enormous implications for some of the most vulnerable Americans, including low-income seniors and people with disabilities. And if you're new to the dual eligible conversation, as I was as a new Hill staffer many years ago, the number one thing I want you to remember is that this is a diverse population with many different health, social, and financial needs, and that means that there are no simplistic solutions. And perhaps even more important, it's important to remember that, as Ariel mentioned, dual eligible is a wonky health policy term that we have applied to real people as a result of the policies we have created around them. Each of the more than 12 million individuals we're talking about today has a unique life story and set of needs. And so here with me today to help us unpack the policy issues that can support or hinder their improved care is an esteemed group of experts. So I'm pleased to be joined today by Denny Chan, who is Directing Attorney for Equity Advocacy at Justice in Aging. In this role, Denny is responsible for developing and leading Justice in Aging's strategic initiative on advancing equity, with a primary focus on racial equity for older adults of color, and he coordinates the organization's equity team. The son of working-class Chinese immigrant parents, Denny has worked significantly on non-discrimination, language access, and healthcare delivery reform issues for low-income older adults, and he brings all of those experiences to his advocacy. He previously served as a rotating law clerk for the U.S. District Court in Los Angeles and participated in the Fulbright English teaching program as a fellow in Macau, China. So super excited to have Denny with us today. And next, I'm pleased to introduce Allison Reiser. She's a principal at ATI Advisory. Allison brings nearly 20 years of health-related experience to ATI Advisory, including more than a decade focused on insurance and government programs. Prior to joining ATI, Allison served as Vice President of Health Policy and Strategy with United Healthcare, where she led the organization's national policy efforts specific to individuals dually eligible for Medicare and Medicaid. And she served as a Medicaid policy director, working with individual states and Medicaid health plans to provide strategic guidance on emerging policy and program trends, in addition to prior years of service with the Lewin Group. And it's great to have Allison with us. Part of what we're going to talk about today is the coordination, or sometimes lack thereof, between the federal Medicare program and the joint state federal Medicaid program. And finally, last but not least, we're joined today by Sarah Barth, who is principal at Health Management Associates. Sarah's policy experience includes extensive work partnering with states, federal commissions, health plans, and philanthropic foundations to lead efforts around state and federal policy requirements, program trends, and market strategy for integrated Medicare, Medicaid managed care models and Medicaid managed LTSS, or long-term services and supports programs. She also has deep operational expertise, including state and federal program oversight, care coordination, communication plans, and facilitating engagement with Medicare and Medicaid. And she was previously Director of Integrated Care and LTSS at the Center for Healthcare Strategies. So we're going to launch today's discussion by hearing from Denny Chan, because as Ariel said, this is a topic with huge implications for health equity. And so it is only fitting that we start the discussion there today. Denny, thanks for joining us.
Great, thank you so much, Sarah. I'm excited to join all of you today, and I say good morning from California, where I'm based, but recognize that many of you are in other time zones. So wherever you are, I hope you are doing well. I'm really happy to be part of today's conversation. One quick thing before I kind of dive into the meat of my presentation. The introduction was wonderful, and one highlight I would sort of offer is that before I took on this new role as Directing Attorney for Equity Advocacy at Justice in Aging, I served for about 7 years as a healthcare attorney at Justice in Aging, working primarily on issues of Medicare, Medicaid, dual eligible integration, specifically here in California. So a lot of what I'll be commenting on and offering in terms of remarks is based on that experience. Next slide, please. Next slide. All right, so if you haven't heard of us before, Justice in Aging, we are a national legal advocacy organization. And our mission is to use the power of law to fight senior poverty. So all of our programmatic staff are attorneys, and we are constantly doing advocacy, whether that's in the courts, policy advocacy at the state or federal level, to ensure that the needs of low-income older adults are being met. We have several primary programmatic areas, one around healthcare, which is where I was working before I took on this new position, another around economic security, including housing, and then a growing amount of work around elder justice and elder rights. And we are celebrating our 50th birthday next year. So happy birthday to Justice in Aging, happy early birthday to us. And in those 50 years or 49 years plus, we have spent our efforts to really focus on those older adults who have faced historical discrimination, continue to face current day discrimination, such as women, people of color, LGBT older adults, and older adults with limited English proficiency, all of which is why we started our strategic initiative to advance equity for older adults earlier this year in March. If you want more information, you can visit our website at justiceandaging.org. We offer free trainings, resources for advocates and other individuals who work with older adults. Next slide. In order to really fulfill our mission to end senior poverty, we really have to acknowledge the ways in which poverty in this country is racialized, that there is both a complicated relationship between the two, that they are not synonymous in terms of race and poverty. Our work also has to address the enduring negative effects of that racism and differential treatment, which compound over an individual's life cycle as they age. And so we make it our focus to promote access and equity in economic security, healthcare, and the courts for our nation's low-income older adults. And that really starts with the recruitment and retention and support of a diverse staff internally, as well as a diverse set of board of directors among many different types of diversity. Next slide. All right, so some of these numbers will look familiar because they were part of the earlier introduction, but I really wanted to unpack who we're talking about here, because that is such an important piece to why this conversation is important. You're going to hear a lot of different policy wonky kind of things in the next hour or so. And I think it's really important for us to focus on who we're talking about. At Justice and Aging, we say dual eligible. We're trying to say people who are dually eligible with Medicare and Medicaid to emphasize the humanity of these individuals so they don't get lost behind the term, but it's a much longer term. So if I slip and say duals, you understand why. But we're talking about a set of 12.2 million individuals who are enrolled in both Medicare and Medicaid. And this is both of a professional interest as well as a personal interest of mine. My grandmother, who I just visited this past weekend, is dually eligible. So it's also a personal interest of mine to make sure that she gets the care she needs. 41% of those duals have at least one mental health diagnosis, and almost 50%, I think the last slide said 49%, receive long-term services and supports to help them get the care they need with activities of daily living, and 60%, well over half, have multiple chronic conditions. So this is a population that needs more help, and they are stuck in two systems that were not meant to work together, because there are a lot of unique issues that happen at the intersection of Medicare and Medicaid. There is an important distinction I want to point out between someone who's fully dually eligible and someone who's a partial dual eligible. Most dual eligibles, well over half, almost 75%, are full dual eligibles, meaning they have both Medicare and full scope Medicaid. But there are some people who are Medicare, who have Medicare, and also receive just assistance through Medicaid through a Medicare savings program. They have no other Medicaid benefit, and because of that, we call them partial duals, and there's a little over a quarter of duals who are partially dually eligible. That's an important distinction because for those people who are fully dually eligible, they really have a lot of issues coordinating between Medicare and Medicaid oftentimes. And then for partial duals, they still, that's still an important distinction because oftentimes only full benefit dual eligibles are allowed to enroll in certain types of plans. And so we'll probably hear more about is all the different types of options that dual eligibles have in considering how they want to get their care. Some more integrated and some less integrated. It's also important to highlight that a growing number of individuals who are dually eligible are enrolled in Medicare managed care, meaning they have a Medicare Advantage plan, whether that's a D-SNP or just a regular old Medicare Advantage plan. It was 37% in 2018, and it was even lower than that earlier years, so it's a trend that's only going up. And then also really important to note that we're talking really about a group who is much more racially diverse than the Medicare-only population, as you can imagine, because of the impacts of poverty, that over 20% of duals are Black, 17.8%, almost 20% are Latino, 6.4% Asian Pacific Islander, and almost 1% American Indian Alaskan Native, which is all significantly higher than the general Medicare-only population. Next slide. I want to talk a little bit about the impacts of COVID-19 on dually eligible individuals. The highlight here is that dual eligibles are more likely to be infected with COVID-19 compared to Medicare-only individuals, as well as more likely to be hospitalized. So what you're seeing here on your screen is the case infection data that the CDC releases on a that CMS releases on a semi-regular basis. So this is, I believe, as of earlier this year. And so it captures really the bulk of infections that occurred over the winter when we were all fighting the peak. But you can see that the blue bars represent Medicare-only individuals, and the yellow bars represent people who are duly eligible with Medicare and Medicaid. Across the board, no matter how you cut it, whether it's looking at people who are aged on Medicare or people who are disabled on Medicare, whether you look at different races, whether you look at different age groups, gender, no matter how you slice it, the infection rate among people who are duly eligible is consistently higher than people who are Medicare only. And that's a really important piece to show both how at risk this group is and continues to be at risk because of the ongoing changes with the variants, and also to show you that really the impacts of being duly eligible, there's something about that intersection of Medicare, Medicaid, poverty, race, all those different things that make this population much more susceptible. And that's true both of COVID-19, but also of other health disparities, which we can talk about later, but is, I think, just really an important note to highlight. Next slide. And so I wanted, before I pass it to other panelists for their kind of opening remarks, I wanted to offer some key considerations as we think about what care looks like, what choice looks like. I think regardless of the vehicle, whether it's a D-SNP or some other type of plan, or whether it's a fee-for-service Medicare, original Medicare, or whatever it is, it's so important that this population, this group of individuals have care coordination from a trusted source. And that can be one care coordinator, it can be a team of care coordinators, but it's so important that at that intersection where we know people need more help navigating a complicated system, that there actually is someone walking them through that system. I think it's also important to highlight the role of states to monitor integrated delivery options. So much of this is different on a state-by-state basis, as you'll hear about later. And so there's an increasing, I think, importance in the role of states to actively monitor what those integrated options look like. The feds can only monitor so much from a high level, but a lot of it's in the details in state policy. I think it's also important to think about, what does choice really mean? I see this with many older adults in my own life that, especially around the annual election period, they get a ton of mailing and a ton of communication about all the different choices they have. And it's great to have choice, but when there's so much choice and it is so hard to tell what differences actually exist between from choice to choice, it can actually feel like there isn't a lot of choice, or that you actually need someone to help you choose. And we don't want to necessarily set up a situation where that's the case. As was said before, the population of dually eligible individuals is very diverse. There are a lot of people who need that extra level of care management or care coordination and would maybe be better off in managed care or some other integrated plan. And there are others who have cobbled together, whether it's over time and trial and error, their own network of providers, some of whom may be with certain plans, others of whom may not be contracted with these plans, but their system works. And to upset that system or to change that system really can offer a lot of risks and potentially not a lot of advantages if that individual is getting the care that they need and their network of providers, their existing system already works. It's also important to make sure that regardless of how integrated these services are, the services themselves are actually adequate, excuse me. And that at that intersection in particular, we know there are specific types of benefits where duals, people who are dually eligible, often struggle, whether that's durable medical equipment, transportation, dental benefits, other areas where Medicaid sometimes is primary as opposed to Medicare generally being primary. We see that dual eligibles face a lot of problems. And then you add on the managed care layer that can introduce prior authorizations, and all sorts of things. It can be then really hard to get the care that you need. So I think all those are kind of initial key considerations I would offer us as we think about, what care really means, what integrated care should look like, and ultimately what care makes the most difference and helps the most this group of very diverse individuals. All right, and with that, I'm going to pass things back to Sarah. But look forward, oh, and here's my email. In case you want to reach me afterward, feel free to email me, but look forward to the Q&A as well. Thank you.
Great. Thank you so much, Denny. That was a really fantastic overview. And now I'm pleased to turn things over to Allison Reiser. Allison, take it away.
Thank you, Sarah. Thanks for the opportunity to you and to Arnold for the opportunity to talk about this important topic today. Allison Reiser with ATI Advisory. Just a little bit of background. We are an advisory services and research consulting firm focused on frail older adults. And I lead our business area focused on dual eligibles and long-term services and supports. And I am just going to jump right in if you could go to the next slide. This is our famous spaghetti graphic, and I've included it here not to talk about all of these acronyms, but rather to show the overwhelming breadth of coverage options that exist for dual eligibles today, because the Medicare and Medicaid programs were not designed to work together. And so we find ourselves in the middle of at least 43 unique program and coverage combinations, really, that policymakers have to sift through as we seek policy solutions. And the actual choices within each of these coverage combinations can be in the dozens. So we just released an analysis and a blog with Arnold Ventures yesterday on this very topic, actually, and found that on average, a dual eligible has access to 26 Medicare Advantage plans in her or his county. And so there's a lot of benefit design within each of these coverage combinations. So Denny touched on this. Is too much choice bad? Is it really choice at all when there's so much to choose from? Next slide. So what this looks like in practice actually varies considerably by state. And importantly, before you even start to think about integration between Medicaid and Medicare, you really first have to recognize that Medicaid by itself can be really fragmented. You conceivably could have a program where a dual eligible has their physical health benefit administered by one organization in one program, their behavioral health benefit administered by another program, their long-term services and supports in a third program. Who knows what's happening with dental, if there's dental coverage, transportation, pharmacy. So you get the picture that even in the Medicaid only space, there is a lot of fragmentation that has to be addressed before you even start to think about Medicare integration. And then you layer on the Medicare benefit. And so there's really two kind of broader approaches to this. There are Medicare only options that are not formally connected to Medicaid. And then there are options that are in some way formally connected between Medicare and Medicaid. So first, those that are not formally connected, the one I'm going to call out here is the acronym that you see at the bottom that says ISNP, ISNP. This is an institutional special needs plan, and I'm calling this out in part because I think it's an untapped opportunity to think about dual eligibles and pre-dual eligibles in a more sophisticated manner. ISNPs are institutional special needs plans that are limited to Medicare beneficiaries who have a long-term care level of need, so long-term services and supports. It is Medicare only. There's no formal Medicaid relationship currently, at least. And it's not a dual specific product, but by its very nature of targeting individuals with long-term care needs, it does tend to enroll a high portion of dual eligibles, again, as well as these pre-dual eligibles who are kind of along the path of spending down into full dual status. So flag again that I think this is one of our untapped opportunities to talk about. And then as we shift over to these sort of like turquoisey, teal combinations, these are the formally connected programs. So the most ubiquitous is the DSNP, the column in the middle. This program is in nearly every state. It's a dual eligible special needs plan. It offers the most flexibility to states. However, at its core, a DSNP is still a Medicare product. It does have an underlying state contract. It is the only Medicare Advantage product that has an underlying state contract called a MIPA agreement or a SMAC, a state Medicaid agency contract. And this contract offers states a ton of latitude to really lean into this Medicare Advantage product and shape integration in a way that is meaningful to that state's residents. This is another untapped opportunity, in my opinion, because of that amount of latitude that states have. Some have leaned into it, many have not. Depending on the state, a DSNP organization may have a companion Medicaid plan They may have other arrangements to cover Medicaid services, or they may not be at risk for Medicaid services at all. And generally, as you look down this list, these acronyms that you're probably hearing kind of floating around right now, DSNP, HIDE-SNP, and FIDE-SNP, generally, as you move down that list, the programs become more integrated. It's not always the case because of the latitude of that SMAC or MIPA contract. A state can actually have a really aligned HIDE-SNP, but that's sort of the spirit of integration as you move down that list. And then another point I want to make on this slide, I'm not going to call out everything, but I do have a reference at the end for you if you're interested in diving deeper on each of these acronyms. But another point I want to make is the Financial Alignment Initiative column that you see here. So you may be familiar with the MMP program, the Medicaid Medicare Plan program. This is the duals demo. I believe it's currently in 8 or 9 states still, and it sits within the authority of the duals office at CMS, or MMCO. This is essentially a singular contract that includes both Medicaid and Medicare services, which is a key distinction between MMP and DSNP. Recall, DSNP's a Medicare program, and it may include Medicaid. The MMP always includes Medicaid and Medicare. However, the MMP, while a very significant and important program, is not the entirety of the duals office Financial Alignment Initiative. So I'm calling this out because it's another untapped opportunity in my perspective. MMCO, the duals office, has this broader pilot authority in the duals space to test out, for example, lessons learned from the MMP in other platforms and chassis. Next slide. So just briefly, all of this choice, all of these program designs, and yet we still find ourselves in an environment where a large portion of the 12 million dual eligibles in our country are in fee-for-service programs. So about 70% of dual eligibles have at least some Medicaid benefits in Medicaid fee-for-service. Creating a comprehensive managed care program for dual eligibles in Medicaid can be very politically challenging at the state level. One of the reasons why we do tend to see a higher rate of fee-for-service in the duals population in Medicaid. However, we also see more than 50% of dual eligibles in Medicare fee-for-service. And so it's really hard to create a coordinated and integrated environment when you have so many individuals still sitting in these fee-for-service programs. But also to call your attention to the last set of data points on this slide, because in the policy world, I think we tend to focus very narrowly. I've heard some buzzwords and some people calling out that these are buzzwords. You know, we think about this only in the context of integration, for example, and that's really important. But the duals population has medical, social, functional complexity, regardless of whether the individual, as Denny was saying, is a full dual eligible or a partial dual eligible, or again, a pre-dual eligible. So I include these statistics to challenge all of us to think about this population as a population that has these complex needs, and we should be solving for these complex needs, one of which happens to be integration. But this isn't just about integration, and so we need to treat it that way because we end up excluding some individuals from programs when we say, okay, only full duals can come in, for example, and then we leave them with really no good plan options and kind of this eligibility cliff where they're left in a desert with, again, not really any good plan options. Next slide. So unfortunately, there is not a single program that emerges as the winner. There are programs I haven't talked about as well that are making their way around Congress, but the reality is the value of a program depends on what you are looking for. And no single program hits all of these boxes. So this is our approach at kind of assessing across some of the key attributes of these programs, like how strong or what the challenges are for each of these programs. And I often say publicly that DSNP comes the closest if the state is really leveraging that MIPA contract. And particularly if the state wants to have a conversation about how to maybe use that financial alignment authority on top of the DSNP. And I say this because the DSNP is easier to implement than the other programs typically. It's easier to scale, it's easy to enroll in, and it has the ability to capture the broadest population. That said, the other programs have some really wonderful attributes that we should be thinking about, but these attributes don't necessarily matter if a state can't afford to implement a program. States have, pretty significant budget restrictions, and so if they can't afford several million or several tens of millions to stand up a program, then that program's not going to ever come into that state. A program also has to be attractive to dual eligibles. They have to be willing to enroll in it. The providers have to want to participate. Health plans, if it's a managed care program, health plans want to participate. So I say all this because, again, I feel like DSNP, coupled with the best aspects of some of these other programs, really has the ability to appease the needs of a variety of stakeholders, the state, a health plan, a provider, and most importantly, the beneficiary. But again, this depends on where a state is in its own infrastructure. Different programs can be more or less meaningful. And also, this assessment is a point in time. This is where we are today. These are the strengths and weaknesses currently. I do think that there is a lot of opportunity to fill in some of these circle bubbles and advance a program or a couple of programs in a way that can be much more meaningful across the duals population and across integration generally. So one last very quick slide before I turn it back to Sarah. And next slide. And this is a list of resources. I just threw a lot of information at you all, a lot of statistics and acronyms. And this is just a list of some of the resources that we've published over the past few months that provide additional detail into many of the points I was making today, including the blog post and the detailed analysis that I mentioned that we pushed out yesterday. So with that, Sarah, I will turn it back to you.
Fantastic. Thank you so much, Allison. And I have to say, like, for myself as somewhat of the queen of overcomplicating things, I'm compelled to quote my mom, who would sort of encourage me to keep it simple, Sarah. And perhaps here today to tell us how we are trying to simplify things for people who are dually eligible is Sarah Barth from HMA. And Sarah and I had the opportunity to work together on a project some time ago, and I'll just highlight that the highlight of that project for me was when somebody said, it's not the people who are complex, it's the system that's complex. So Sarah, take it away.
Thank you, Sarah Dash. Thank you to the Alliance, and thank you to Arnold for the commitment to simplifying and improving care for individuals with complex needs, including individuals who are dually eligible for Medicare and Medicaid. Next slide, please. Kind of obligatory, my firm, Health Management Associates, would not like me to reference it that way, but I've been at HMA. I'm a principal there for the past 5 years. We are an independent national healthcare research and consulting firm. We work nationwide. We work on publicly financed healthcare systems with providers, health plans. A lot of the work that I do is with foundations, advisory committees to Congress, and we are devoted to improving the quality and cost effectiveness of our publicly financed healthcare system. Next slide, please. I just want to say thank you to Arnold Ventures for funding what we just currently wrapped up, a 2-year Medicare and Medicaid integration project. Just wanted to highlight, we have 3 briefs. I'm going to be focusing on the 3rd phase of the research, but the first phase focused on enrollment rates in current integrated care programs. Many of the models that Allison highlighted, we defined for our research, just to help put context here, ICPs as financing and care delivery organizing entities or programs that coordinate and integrate Medicare and Medicaid coverage services and supports for dually eligible individuals. So those dual demonstrations, some of those aligned health plans across Medicare and Medicaid. I'm not going to go down a rabbit hole of details, but research showed that, and other research, that currently about 1 in 10 of people fully eligible for Medicare and Medicaid are enrolled. So that led to a question, why? Are they not enrolling, or are they not staying enrolled? Second issue brief and part of the research was, so what, for integrated care programs, what have been the barriers? What have been the successes? What are some of the unanswered questions? And which led us to identifying essential but really necessary program elements for these integrated care programs that people want to enroll in, stay enrolled in, because they meet their needs and preferences and are tailored to the diverse needs of the dually eligible population. Next slide, please. So some of this has been covered. The context was laid out by Sarah, Ariel, Denny, and Allison. So I'm just going to go over a couple of these that, we do have that dually eligible individuals more often than not are navigating separate programs not designed to work together. There have been promising models that the states and federal government have worked on together. And as I said, but currently only 1 in 10 individuals, dually eligible individuals, are enrolled. And we just, from our research and interviews with stakeholders in 4 states, to really increase enrollment, policymakers need to continue. They have, but continue to partner with consumers to design programs that meet their diverse needs and preferences, and as Denny underscored, really address health equity. As Allison highlighted, states really, and input we received, really need federal support. This is important, complex, hard work. States have limited budgets, competing priorities, and they have a significant role in implementing and overseeing these programs. Next slide, please. So from interviews with stakeholders in 4 states, from a highly integrated, from states with a highly integrated program to states that do not have any integration activities currently or low, and they would be, the spectrum would be Michigan with a dual demo, Pennsylvania with a Medicaid managed long-term service and supports and aligned dual eligible special needs plan model, and then 2 states with, to a lesser degree, a level of integration in their programs, Oklahoma and Louisiana. I'm not going to go over these categories because they are on the next slide, which is my final slide. I know we want to get to the discussion and Q&A. So from discussions with stakeholders that included consumers, community-based organizations, state Medicaid administration officials, many fully integrated dual eligible special needs plan, a behavioral health managed care plan, we heard, and I would say a lot, but what bubbled up to the top were these, or just what we heard repeatedly, these 10 areas that, as Sarah Dash noted at the beginning, we've been working on these and highlighting many of these and working on them for over a decade as we try to integrate care in the states and federal government's partner. So I just am going to go through these quickly and hand it back over for Q&A. We also identified some policy recommendations for each of these elements that hopefully we can talk about during the Q&A. So the first area was when we talk to people, and particularly consumers, the confusion starts before enrollment. It starts with eligibility and eligibility for the 2 programs, and particularly Medicaid at the point of turning 65, and you have to be redetermined using different eligibility criteria. It's in the brief, it's complicated, but what came out was we need a simplified Medicare and Medicaid eligibility processes and paperwork that is understandable. Next, individuals need expert advice to help them navigate their options and the information as to the benefits to determine which program, which health plan is optimal for them to enroll in and want to enroll in. So then the next category, the delivery of care and support. What was underscored and what Denny really highlighted is, the diverse dually eligible population. We need to engage the diverse consumers to inform and tailor the delivery systems and these integrated programs to their needs and preferences. There needs to be a robust data infrastructure, both at the population and individual level. So all their characteristics, not just their medical needs, their social situations, their social challenges, and really have that information to drive health equity. Then coordinated efforts to address their social needs, housing, food insecurity, transportation, a single process for assessments and plans of care, and one care team for each consumer. And I would note the dual demo, the capitated financial alignment, and the program, PACE program of all-inclusive care for the elderly requires this, but as we move forward, really need this in other models that emerge. There's a lot of work around quality measurement, and not to add to quality burden, but really interviewees highlighted the importance of key quality indicators for consumers that are important to them as my provider in this plan, this program. Are people disenrolling? I should ask the question, why? How many people are supported with really high needs, maybe nursing facility level of needs in the community over institutions? So the need to really put together just some key indicators to help people choose between plans and between programs. Then payment models to incentivize really quality of life improvements, community engagement, and things that individuals receiving services and supports want and need. And then what really emerged were two areas related to access. And the first one, an adequate, engaged, and diverse workforce to support individuals and to support them where they want to receive services, how they want to receive services. What was really highlighted was the adequacy of the direct care workforce for those individuals. And as Ariel noted, really high number of, or most dually eligible individuals need assistance with activities of daily living, and we need an adequate direct care workforce that can support people in their homes and community. And then also access and needed services in rural areas. In Oklahoma, they noted as you move out to more rural areas, yes, smaller population, but higher prevalence proportion of people are dually eligible individuals. And I also have to say, having been the Bureau Chief for Long-Term Services and Supports at New Mexico Medicaid and standing up a program, that this is an area near and dear to my heart to really increase access in rural areas. So I ran through that quickly, but I wanted to hand it back over. Next slide, actually. And just wanted to highlight that the brief is out there, but we also have a fact sheet that is easier and shorter to read. So you have links right there. And thank you very much.
Thank you so much, Sarah. And why don't you stay on camera? I'm going to invite everyone else to come on camera. While they're doing that, thank you all for calling out the great resources. And I want to call out just one more. The Alliance for Health Policy recently published a health policy handbook. It has a chapter on dual eligible beneficiaries, and it was also supported by Arnold Ventures. We're going to ask folks to put that in the chat for my team. It is a great resource. It's written by a phenomenal bipartisan team of health policy veterans, Rodney Whitlock and Purva Rawal. It's in partnership with Health Affairs. So check that out for some more information. So thank you all for the really terrific overviews. And I just want to start off, a lot of you use this word integration, and we've already had some terrific audience questions come in. And so I'm going to try to combine them a little bit. But Sarah, especially in your last slide, it seemed like those were some of the perhaps characteristics of what an integrated care system would look like. But is there a common, definition or understanding of what that looks like? And how does that differ from the perspective of the policy and practice community and then the perspective of the consumer? So maybe let me start there and see what your responses are.
Is that directed at me, or I don't want to just jump in? You just heard from me. Okay.
Yeah, go ahead.
Okay, thank you. Yeah. And I just want to, in answering this question, reference an interview that we had with a consumer. The word integration doesn't mean a lot to them. They just want to know that they can get the care, the services, the support from the people they have relationships with and in the communities in which they live, and from a person and providers who understand their living situation and all of their needs. So I would say integration is really addressing the whole person. I may be, sidestepping your question, but really this word there isn't a uniform definition of integration anywhere. And it is, I just think what I just said, that people have access to services and care that work together and that they don't have to put together themselves, that it is a seamless system that addresses their whole person.
Great,
I would
thanks.
just
Danny,
add,
Danny, you're nodding. Go ahead.
I would just add, I think the word integration appeals to us because we know that the silos exist. Dual eligibles, people who are dually eligible, are so confused by all the systems that the word integration, to Sarah's point, doesn't mean anything. I think ultimately the ultimate test is whether they get what they need in a timely way and in a way that is person-centered. Another way that I think about it too is the plan actually, is the option, whatever the option is, right? Is the current system actually one that someone could navigate without someone else's help? And whether that means that you have someone who is doing a more of a care coordinator role, or someone who's helping manage inside, are there barriers to getting the care that they need? I see this regularly with my own grandmother, who I said at the very beginning is dually eligible. Just getting her to the doctor's office is like, it takes a team of her people in her Medicare plan, plus all the caregivers, plus my family. I mean, it is such a feat just to go for a regular office visit. That if you said to her, oh, is your plan integrated enough for you? She would have no idea what that means. She just knows it's a big hassle for her to get to the doctor's office to get what she needs. And I think that's how it shows up for consumers. So really, I think we've said before multiple times, it's about simplicity. And I think we need to make sure that the system is simple enough, but also flexible enough to meet the needs of the people who are enrolled.
That's great, and I want to ask you a follow up, and then take a slightly different tack for Allison, but also related to this integration question. And Denny, we had a question from the audience about, do you have a recommendation, or what is your best recommendation for providers to assist their dual eligible clients? This particular one comes from a small home care agency, but like, who do people call? Is it the plan? Is it the state? Like, is it the county? Is it you? Like, who do they call?
I should have clarified in our introduction that we don't offer direct services, so we are not the people to call. I think part of why the word integration is so appealing is because there isn't oftentimes one answer to that question of who to call. I remember when we were working on the California MMP, the Medicare and Medicaid plan financial alignment initiative, the catchphrase that the state really hooked onto was one phone number, right? And that was great because it was an integrated plan that was offering Medicare and Medicaid services. So that phone number oftentimes would do the trick. But I'll even say that even when it was one plan that was offering Medicare and Medicaid services, that oftentimes with carve outs and other sort of very wonky things that we don't have enough time to get into, that was actually slightly deceptive. There was a phone number to call, but then there might be someone else to call, or there might be two warm handoffs or something else. So I think part of it is, can we create a system, regardless of how integrated it is on the back end, that it's at least integrated for the consumer, right? So they do have only one phone number, regardless of whatever plan they're in. And then we, as the wonks and everyone else behind the scenes, can work out the systems behind that. But I think it is really important for consumers to have one touch point. And unfortunately, I don't think we have a very simple answer to that question right now.
Yeah, and for those who are kind of newer to the conversation, carve out is not a fun barbecue term. It is like, what it means is like maybe your behavioral health benefits might be coming from a different plan. And as we saw from, Denny, from your slides earlier with, I think it was almost half of folks in this, population having a mental health condition. Those are some real considerations. So Allison, I want to turn to you because, we've had a couple of questions around policy levers, right? Regulatory, congressional, legislative, and like, what are some of the things that can either move the needle on integration or, make it, make a big difference. And you mentioned the Medicare Medicaid coordination office, and I just think it's important to call out that is that office is about 10 years old, right? That was created during the ACI. So can you talk about like what have we learned? These were some of the same things we were talking about before the creation of that office. That office has created some the financial alignment demos to like really try to grapple with these problems. But like, what have we learned, and how do we move the needle in the next 10 years, or hopefully less, or hopefully do even more than move the needle, right? Like make care and coordination a lot better for folks. Allison, you want to take a stab at that really easy question?
Yeah, the million-dollar question. I think what we have learned that whatever the solution is, it has to work for all stakeholders. Like, we can't just design something that is ideal on paper, because then we probably won't be able to execute against it unless we completely rewrite Medicare and Medicaid, right? Because we have choice in Medicare, wide open choice. That is a policy conversation to have, but we have wide open choice. We've got state designed Medicaid programs that really are 56 different programs with carve outs and all of these other wonky terms. And so it has to work in the Medicare space, it has to work in the Medicaid space, but guess what? If we want to do this in a risk-based way, it's got to work for health plans. Like, we've got to figure out a way how to bring the health plans along and how to bring the providers along. So I guess my point is not necessarily about like this one thing that does this really great job at coordinating or improving. We have to figure out the solution that is sustainable, that brings in the most number of dual eligibles, and that works for all stakeholders, which is one of the reasons why I tend to go back to DSNP, because it has been the most popular among dual eligibles. You're able to sell. Now, that's a separate policy conversation, should you be allowed to sell at all, but you're able to sell, so we can maximize enrollment in those programs. There's a lot of latitude for a state to design those in ways like wherever their readiness is, because we're not just going to flip the switch and everyone's not just going to be Massachusetts overnight. So we have to let states stair step into this, right? So I think that's maybe not a satisfying answer, but I think that is, again, kind of one of the big things from my vantage point that has been a really important lesson learned, where we see lookalikes popping up. That's another term that we're not going to dive into probably today, but we see all of these whack-a-mole solutions that pop up in response to the ideal policy environment, and that's just not sustainable.
Yeah, and one follow-up for you, and I want to talk a little bit more about this, state and federal dynamic, because it's a problem of, there's a lot of cooks in this kitchen, right? And when we think about, one of the things in particular that I think has come up in the policy conversation, although not yet in this conversation, is this idea of like, if you make something work that, let's say, keeps someone who's in a nursing home and therefore receiving, Medicaid benefits, if you keep them out of the hospital, right, that's like a Medicare savings. So this question of, and again, in wonky policy community, we like to call it the wrong pocket problem, although I like to say it's all taxpayer money in the end, and consumer money and time and energy. But like, have we come any further in dealing with this issue that, the money is coming from different buckets, and therefore perhaps there's sometimes some reluctance to like implement a solution that might work for people, but is sort of not a budgetary solution, if you will.
Yeah, I think there's kind of two answers to that. The first is like the state perspective, and the second is the plan perspective. And from the state perspective, that is still absolutely, I think, the typical sort of sentiment that why invest all of this money in an integrated program if the savings are going to accrue to decreased emergency department utilization and hospitalization. That's a Medicare savings. That is, I think, a space where the MMP, really got it conceptually right, was figuring out how to share those savings back to the state. That's where I would love to see the financial alignment authority applied, potentially outside of DSNP to scale the ability of states who don't have MMPs to scale their ability to share in some of those savings. There's also the long-term payout of we are also slowing or preventing institutionalization, which then becomes a Medicaid covered benefit. The challenge with that is that the tenure of a Medicaid director is less than 2 years. It's way less now that Tom Betlach left, right? So it's hard for them as they think through like this annual budget cycle, and I've got 2 years to do everything I want, and it's really politically hard to do it. It's hard to think about the long-term payout, but there is an increasing amount of evidence to states that yes, in fact, this can help save dollars long-term. I think from the plan perspective too, this is where I think PACE gets it really right, which is you've got your bucket of money. It doesn't matter if it's a Medicare service or a Medicaid service or even sometimes a social service. You've got your bucket of money. Use it as you need to for this individual. And I do think we're starting to inch closer to that. CMS had released guidance maybe a month or two ago on how to use supplemental benefits in Medicare and ways that states can set their rates in a way that starts to blend those dollars. But at the end of the day, you do still have, like as a plan, you've got your Medicare dollars, your Medicaid dollars, you've got to encounter against each of those. So we do still have some of those barriers.
Yeah, thanks. And I will note we have about 5 minutes left. I think we need, clearly we need like a 201 and a 301 on this really important topic, to just because it's just layers and layers. One of the things I do want to mention or ask about, in terms of, and I'll direct this to Sarah, Barth, and then to Denny in terms of policy supports. You mentioned kind of broader supports for long-term services and supports. There's obviously a big proposal out of the Biden administration on home and community-based services. What impact, if any, would the idea of increased availability of HCBS have for the duals population? What is the crossover?
So I just want to sort of unpack your question. You said, what are the incentives needed, and then sort of the importance of HCBS to this population?
Yeah,
okay. Okay, so the incentives, I'm going to jump to something we've really heard. States need support, and they called out they really need federal support for the capitated financial alignment initiative. Some of these states received, grant money. They also need support to, I don't know if I'm answering your question, but really to hire expert staff. They have limited budget to hire staff, just for the Medicaid program, but people who are expert in Medicare and Medicaid integration, and really supports on information technology, data sharing, and the importance of HCBS for this population is they all need, a majority need assistance with activities of daily living. I don't know if I really navigated those two parts of the question well.
Well, let me ask Denny. In terms of we're sort of talking about this, and we've been talking a lot about the financing as though like the resources are out there in the community, right? And so talk about what is that capacity, and Sarah, I don't know if you want to start, and then we'll give Denny.
Yeah. Well, and that gets to really the adequacy of the direct care workforce, really making it, some states have partnering with maybe community colleges, universities, really making it a career, and it's something that is recognized as important. Direct care workers provide really essential services to people. They have close relationships with them. They can identify when there's a change in circumstance, and that could be very important to the health plan or anyone, to put an intervention in there or support to avoid a trip to the emergency department. And I just think that there need to be more incentives for people to want to enter this profession, including, sorry, I sound like I'm, a cry here, but wage. Are they paid a living wage for what they do? Or are they recognized as important and incorporated into the integrated care team as having a voice? They know the individuals. I don't want to take all the airtime here, but there are ways states can partner with universities and other entities to really try to raise the profile of the importance of this profession. And Denny, I'm going to let you jump in. I see you.
I'll just say two things really quickly because I know we're coming up on time. The first is that, obviously we support the proposal. We think even that the amount of money that's been proposed, the various amounts, none of it is actually adequate. It's all just sort of, it's all really, it'll be really helpful, but it's not going to actually like meet all the HCBS needs of dual eligible individuals. The second thing I'd add is this is a race equity issue, not just because of the people who we're talking about, but because if you think about how we compensate based on who is doing the work and our notions about what that intrinsic value of the work that's being done, caregiving and that kind of related type of work is both suffers from sexism and racism based on who's doing that type of work. On the flip side, on the consumer side, we also know that communities of color, dual eligibles of color, are going into nursing facilities at higher rates than white adults. And that partly that is because HCBS is not being made available in the same ways. And so if we're putting in money toward HCBS system, there's both race equity implications for people who are giving those services as well as people who are receiving those services.
Thank you. That's such a great point that, it's as always, right? Like none of these policies are monolithic, and we have to think about equity considerations throughout each and every step. Denny, I want to take moderator's prerogative and give you the final word, but really I want to give your grandmother the final word, right? Like as one of 12 million of these, individuals, what do you think she would say? What do you think she would ask for of her policymakers?
So I don't want to speak for her, but having just seen her this weekend, I will try and channel sort of her spirit to the best of my ability. She's both so thankful for what she has as an immigrant, 88-year-old immigrant woman, but also I think her key message to policymakers would be, make a system that works for me. Let me get the care that I know I need. I know what my needs are. Don't put the burden on me to figure it all out, but create a system that actually is responsive to who I am.
Thank you so much. And so with that aspiration in mind, I want to thank you, Denny, for joining us, and Sarah, Barth, and Allison Reiser. It's been a pleasure to speak with you today, and certainly hope to have you back sometime to delve into some of the deeper issues that we raised today. Thank you, Ariel Muir and Arnold Ventures and the Complex Care team for making this event possible. And please, again, check out allhealthpolicy.org and the handbook for more information. And feel free to reach out to us anytime with suggestions for future programming. With that, we'll end today's webinar, but certainly not the work. Thanks, everybody.